Hello, everyone. Thank you so much for joining us. Good morning, good afternoon, good evening. My name is Colleen Daniels, and I'm the Deputy Director and Public Health Lead with Harm Reduction International. Along with our co-sponsors, Input, Médecins du Monde, UNITAID, and the University of Bristol, we're really happy that you can join us today to talk about low dead space syringes. And it's really nice to see the excitement about these technologies that are coming out and how we can probably work together and collaborate to implement. We do have interpretation for this webinar and available in French, Spanish, and English. If you have a look at the bottom of your Zoom screen, you'll see a little icon that looks like the world, and you can click on that icon and then choose your language. So if you'd like to do that, we can then get started. So as many of you know, there are many tools for HIV and hepatitis C prevention for people who use drugs, though access, availability, and accessibility still remain a challenge in many countries. Low dead space syringes are one of those tools, and it's actually hypothesized that they can reduce HIV and HCV transmission risks. And recent modeling actually estimated that removing the transmission risk due to injecting drug use could prevent up to 43% of all new hepatitis C infections globally. Further modeling also showed that low dead space syringes could result in a decrease for both HIV and HCV prevalence. And recent threshold analyses indicated that compared to high dead space syringes, detachable low dead space syringes would only need to reduce the risk of virus transmission by 0.26% to be cost saving, and 0.04% to be cost effective in an environment like a high income setting. So on that note, let me introduce our first speaker. We are really blessed to have an amazing panel of speakers today, and I'm so grateful to all of them for being willing to join us and share their expertise. And do please let us know where you're coming from in the chat. We'd love to know where you are and what you do. So our first speaker is Karin Timmermans, who is a technical manager in the strategy team at UNITAID, where she works, amongst other things, on hepatitis C. Before joining UNITAID, she worked on access to medicines and pharmaceutical policies in different countries in Africa and Asia. Welcome, Karin. Thank you so much for joining us.
Thank you very much, Colleen, and thank you to Harm Reduction International, Médecins du Monde, Input, and others for having me here. Can people see my slides? Okay. Yeah, I'm delighted to briefly speak at the start of this very interesting webinar. And as many, or at least maybe a number of people who are on this call probably know, UNITAID was among the first global agencies that started to work on hepatitis C now about 10 years ago. And our initial focus really was very much on testing and treatment of hepatitis C. More recently, we started working also on the prevention of new infections, and largely for the reasons just mentioned by Colleen, we realized that in order to really reach the WHO elimination targets, we also need to prevent new infections, and it's not enough. We're not going to get there by just testing and treating the current infections. So to prevent, we sort of obviously focused on people that have a high risk of acquiring hepatitis C infection. And then we are talking, for example, of people in prisons and people who inject drugs. So that is how we de facto entered the harm reduction space. And we quickly learned that there are tools in existence that can reduce the risk of hepatitis C infection for people who inject drugs, as well as the risk of other infections such as Hep B or HIV, the low dead space syringes and needles. We also learned, however, that the uptake of these important tools has been limited, certainly in low and middle income countries where UNITAID focuses its efforts. And from my perspective, from my understanding, that seems to be due largely to three main reasons. The first one is that I think there are misconceptions about the products, both among people who use drugs, but also among others, such as ministries of health, procurement agencies. And there's a lack of information and awareness that low dead space syringes actually can significantly reduce the risk of infection. There also seems to be a misalignment between what people who inject drugs, what they need or what they want, and what they actually can get. So a misalignment of, for example, the size of syringes on offer. And then there seems to be, that's also quite important, a mismatch often between the price of these syringes and the available funding. In my perception, low dead space syringes are not very expensive tools. UNITAID works on many products that are much more costly, but nevertheless, they tend to be, speaking under the authority here of others on the call, on the webinar, but they tend to be more expensive than ordinary syringes. And that poses a challenge in an area such as harm reduction that generally is underfunded, certainly in low and middle income countries. So I guess these problems are perhaps quite well known to most people on this webinar. So I've also put a little box like UNITAID. Again, as many of you may know, we are working with many partners under the leadership of Médecins du Monde, as well as PATH and Frontline AIDS. We are having large partnerships in place, and we try to really address some of these challenges by working on a number of the things that you see in the gray box. I will not read out all of them. I think it's largely self-evident, but I do want to focus maybe the attention on the bullet in the middle. I think one of the things that we are really serious about trying to do is to do something that is perhaps so simple that I understand it is at times forgotten. We really want to start by asking people who use drugs, like, what it is that they want and what it is that they need. And with that, I'd be happy to hand it back to Colleen, I think. Thank you.
Thank you so much, Karin. And I think you have hit the nail on the head with those challenges that we currently have, and hopefully we'll hear a bit more about how we can overcome some of those from our other speakers. So next up, we have Ernst Wisse, who is with Médecins du Monde. And actually, when I asked Ernst for his bio, he said, just say Ernst, blah, 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 from Médecins du Monde. So I was going to do that, but then I thought, no, let me talk a little bit about this amazing person. So Ernst has a background as a nurse and has worked as a field worker and later as a manager in multiple harm reduction programs in many low and middle income countries. He holds a master's degree in public health from the London School of Hygiene and Tropical Medicine and is currently the harm reduction expert at Médecins du Monde. Thanks so much, Ernst.
Thanks, Colleen. The blah blah would have done. It's fine. Very nice to be here. Thanks all. I'll jump in immediately. And I see in the chat a lot of familiar names coming up. So can't see you, but very nice that you're all here. I'm not going to say anything new, I think. So if you need a coffee, this is the moment, and then you can listen to some of the other amazing presentation. But I will just try to help, frame maybe a little bit the discussion of the low dead space syringe. So just to start off right away, number of people inject drugs. I just pulled out a number here, but there's multiple floating around. I think we've all seen numbers between, I don't know, 11 and 16 million over the last 5 to 10 years. Obviously, it's very hard to pin this down, and I kind of wanted to put this image here already straight from the start, because when you talk about providing needle and syringes, we're talking about access, and most of the people who use drugs are pushed out of our societies, and that's part of the problem of needle exchange programs to start with. Now, if we look into the public health perspective to this, again, all familiar images to most of the people on the call, I presume. 1 in 5 new HIV injections are suggested to be part of people by people who inject drugs. If you look into a different perspective, that means that they are 29 times higher at risk of acquiring HIV compared to the rest of the population. And if you look into hepatitis C, I think I've seen an estimation between 3 and 4, 1 in 3 to 1 in 4 new infections of hepatitis C are among people who inject drugs. So that's just illustrates the importance of preventing this, and the way you prevent this. And here we come to the WHO guidelines. Is we know that NSP has the greatest impact in preventing transmission of HIV and other bloodborne diseases. And then the second point, again, framing the discussion of low dead space syringes, the problem is that there is an extremely low coverage of NSP and other preventive measures. Now, I can never really speak about NSP without mentioning that they are part of a bigger approach. It's a harm reduction approach. NSP is a tool, and within the NSP, low dead space syringes is again a tool. And I think we should really approach this looking into the broader implementation, the broader harm reduction approach, and then within that you can provide additional tools. So I just wanted to point out again that NSP is part of a harm reduction approach. So coming back to the WHO recommendation, I don't really need to read this. Everybody knows it. The WHO recommends all individuals for key populations who inject drugs should have access to sterile equipment. So now the reason why we speak about low dead space syringes is because they can provide additional protection. But then the discussion often is framed around, yes, but people should just simply have clean syringes always, every time. And we all agree on that. And I really want to put that out again here in this webinar, because sometimes the discussion slips into, yes, but people should just have more syringes. Yes, we agree. The problem is that we are facing lots of structural barriers. And I think a lot of people here on the call today, we know that we are facing stigma, social exclusion. We work with people who use drugs that are pushed in the most shitty places of society. It is very hard to make sure that people have always access to clean syringes. Therefore, if we have tools that can prevent people that don't have a clean syringe, that at least the syringe might prevent some additional protection, I think that is really important to try and make those tools available. So what is a low dead space syringe? Look, you're going to see a lot of schematic representation of low dead space syringe through this webinar. So I just wanted to look, this is a familiar image to many of us, outreach settings. If you look a little bit closer, here's the syringes that you would find. And if you look at really closely, this is what we're talking about. If you have a syringe, there is empty space in the needle and there's empty space in the syringe. Once somebody has used it, most of the times they flush in the end. It means that when the syringe is done, that empty space has been filled up with blood. And as you can see, you will see blood in the tip of the syringe and blood in the needle itself, like in the blue bit of the needle. That's what we're talking about. Now we call these syringes high dead space syringes. But they are the normal syringe that you would find basically everywhere. And any efforts to reduce that space, we usually call low dead space syringe. And I'm sure we will speak more about all the different variations of that to come. Now, less blood remaining in the syringe, theoretically, less virus remaining in the syringe, less risk of transmitting the virus. That's what the theory wants. That's what Colleen already referred to earlier on. And therefore, the WHO recommends for many years already that it is suggested that every needle exchange program should introduce low dead space syringes as an option for people who use drugs. So I really promise to stick to 5 minutes. So I'm already jumping to the end. Yes, Colleen is laughing, but she told me she would kill me if I wouldn't stick to 5 minutes. So just on a note that, again, low dead space syringes should be seen in the bigger picture of providing harm reduction. And all of our programs should do the best we can to make sure that we have access to everyone anytime. Thank you. I'll stop here. I think you're muted, Colleen. Sorry.
Oh, thank you so much. I'm talking to myself yet again. Thank you so much for that. And I think that's really important, that point, that these WHO guidelines have been out for a long time. And they just, and in many in situations, they just haven't been implemented. And we want to be able to have everybody who needs these tools and wants these tools to have access. So thank you so much for that and for keeping in time. I appreciate it. Our next speaker is actually the author of the report that we published at the end of last year, Robert Csak. Robert is a sociologist with a PhD in health science research. He worked in needle and syringe programs for 10 years and did research on various topics from needle and syringes, their use in marginalized communities to consequences of decreasing coverage of harm reduction services. Robert has been working with HRI since 2020 and has contributed to various reports and research projects, as well as the last 2 editions of the Global State of Harm Reduction. So Robert will give us an overview of the findings from the report. Thanks, Robert.
Thank you for the introduction. And yeah, just a sec. Okay, so I will talk about briefly on the results of this research. To save time, I won't talk about methodology here, but all details are included in the report, so please download it from HRI's website and check it there. So we asked about funding, and funding for aerospace comes from both international and national resources. I'm sure that the audiences know this, but in our results, international funding is the primary and often the only source of funding for harm reduction in low and middle income countries in our sample, and this international funding is almost exclusively provided by the Global Fund. And programs that are domestically funded are found in high-income countries. And syringe procurement is somewhat centralized in most countries. In countries where the Global Fund is the main source of funding, usually the principal recipient purchases all harm reduction equipment and distributes it to the organizations implementing harm reduction programs. This process can lead to different results in terms of the type of available syringes. So basically, for example, in Kyrgyzstan, all syringes are purchased centrally. They offer a wide range of syringes, but they are only buying high density syringes because those are cheaper. And the same process lead to only one type of syringes at needle and syringe programs in South Africa, because they are only buying insulin type 1 milliliter fixed syringes with fixed needles. So only low space syringes are offered in needle and syringe programs there. But in countries where national or local governments fund harm reduction services, needle and syringe programs can obtain their equipment according to public procurement policies. But these can also hinder access, and lead to unfavorable outcomes. So North Macedonia is a good example, because that's the case, I think, in many countries. So service providers can only order their equipment through a public procurement system, and they must choose the cheapest option, even if it's not the best quality. So in the majority of countries surveyed, needle and syringe programs are the main source of injecting equipment for people who inject drugs. So in 16 out of the 22 countries where we had estimates on pharmacy access, the data indicates that more than 80% of injecting equipment is distributed through needle and syringe programs. However, pharmacies can play a role when needle and syringe coverage is inadequate. So in Georgia, for example, needle and syringe programs are implemented in only 11 cities. So people who inject drugs in other cities have to buy the equipment in pharmacies. Similarly, in Mauritius, people who inject drugs use pharmacies because harm reduction services have difficulties reaching every part of the island due to limited number of harm reduction workers due to limited funding. And there is an important exception, which is Scotland, where pharmacies are an integral part of the harm reduction response. So the majority of injecting equipment provision outlets is pharmacy run, but these pharmacy outlets offer the same type of syringes as traditional needle and syringe programs. But in general, pharmacy access is not ideal because access can be hindered by stigma and discrimination. So pharmacies often refuse to sell syringes if they suspect drug use. And also, people can access a wide range of services in needle and syringe programs, and this is not the case in pharmacies. On syringe type, so the most common type of syringe that is available in our sample was traditional high dead space syringes with detachable needles, they are available in all countries in our sample except Colombia, Puerto Rico, and South Africa, because these 3 countries offer only low dead space syringes, like insulin type syringes. These traditional high dead space syringes with detachable needles are available in many varieties from 2 to 10 milliliter syringes, so needle and syringe programs typically offer 2 or more varieties of syringes. And the most common low dead space syringes are these insulin type syringes, which I'm sure everybody is familiar with. And these are available in most in NSPs in most countries, but they are not ideal. So there are many problems with that. So they are too small, and the needle is not suitable for deeper veins. Or for example, like larger needles and lengths are needed to access deeper femoral veins or intramuscular injection. So furthermore, injecting homemade drug mixtures or prescription drugs or any large volume drug solutions in general require larger volume of syringes. And also I have to mention that detachable needles can have practical benefits. So for example, they can be replaced if they become blunt or clogged because of bad quality drugs. And low dead space version of larger volume syringes with detachable needles are only available at NSPs in Scotland right now. They were available in Ukraine during a pilot program, but they stopped distributing it because they were unpopular among the clients. This is just an illustration, so there are a lot of data and a lot of detailed information in the report. So I would recommend to download it and read it there. An important thing that we also asked service providers about client preferences, and I'm sure this is not so I'm sure everybody knows this, but the quality of the equipment is also an important factor. So there are many places with a similar situation. So, but we have an example from North Macedonia where clients don't consider the dead space, but rather the sharpness of the needle and prefer a specific brand that is perceived to be sharper and better quality than others. Stigma and discrimination of people who inject drugs also plays a role in syringe preferences, because some choose thinner needles because they leave smaller marks, which are easier to hide, or inject to femoral veins instead of more visible braces. And this is, we have more examples in the report, but this is the case in Greece, where younger people who inject drugs tend to inject to the groin because that's less visible. And additionally, chosen syringe types can reflect culturally mediated behaviors. For example, peer initiation and early experiences of injecting can influence injecting practices and equipment choice. And equipment can become an important part of injecting rituals, and these can help overcome difficulties like injecting while in withdrawal. So these things have to be considered when you want to introduce a new type of syringe, for example, a low dead space version of larger barrels. Okay, I have to talk a bit about mathematical modeling. Our colleagues at Bristol, Jack Stone and Peter Wickerman modeled HIV and hepatitis C transmission among people who inject drugs to estimate the impact of increasing provision of low dead space syringes by needle and syringe program in 16 countries. Using our data from the report. I won't go into details, but I'm hoping that they are available in the seminar because they are in the audience. Yeah, but to sum up the results, they found that if needle and syringe program switch from providing high dead space syringes to effective detachable low dead space syringes, then 15% of new hepatitis C infections could be averted between 2024 and 2030 across the countries with high needle and syringe program coverage. Though the impact is less in countries with low needle and syringe program coverage, this switch could substantially increase the impact of scaling up of needle and syringe programs. Okay, so I won't do this sum up because I'm over the 10 minutes time frame.
No, please go ahead, Robert. Let's do this.
I will end here. Thank you.
No, Robert, go ahead. You can do the summary.
Oh no, I just wanted to highlight that what Ernst already mentioned, that low dead space syringes are an important tool, but high coverage of needle and syringe programs should be prioritized and use that as a tool to improve the effects.
Thank you so much, Robert. And please, if you have any questions for the panelists, you can pop them into the Q&A. We'll have time later to come back to them and we can actually call on you to ask them. Moving on now, we'll start looking at some of the implementation that's been going on around the world. We have Abdullahi Muktar is our next speaker, and he's a harm reduction activist and drug user since 2015. He joined drug-free and preventive healthcare organizations in early 2018 as a peer and then became a peer educator. He currently leads the outreach department of the organization, supporting activities and programs for their community support group of people who use drugs in Gombe State in Nigeria. He is from Gombe State and is currently studying public administration at Gombe State University. Paulina and Suchi, could you please bring up Abdullahi's presentation? And I can't see him now on the screen, but Abdullahi, please just let us know when you'd like us to move to the next slide. He was with us, and I see that they've been having some internet issues in Nigeria, so I see that he's reconnecting. There was some damage to underwater cables. Okay, Abdullahi, we are ready when you are. Please just let us know when you'd like us to move to the next slide.
Hello.
Hi. You may not have heard me, Abdullahi. We're ready when you are. Just tell us when you want us to move to the next slide.
Yes, I'm ready now. I'm ready for.
Okay. Next slide, please, Paulina.
So
go ahead, Abdullahi.
Yes, thank you, my friends in Impute, HRI, and MDM for a chance to share a feedback on low dead space syringe in Gombe State in Nigeria. My name is Abdullahi Muktar. I'm an outreach worker at Drug-Free Preventive and Healthcare Organization. DAPO is a drug-free organization that was part of the National Needle and Syringe Program pilot that was founded by the Global Fund and implemented under the auspice of Nigerian Federal Ministry of Health. I started this development journey as a frontline peer worker, distributing needle and syringe in the places where I also bought and used syringe drugs. 3 years on I have progressed to be an outreach worker. Then I got married and I have taken a course in public administration as in the Gombe State University presently. I am grateful to the sense of purpose and opportunity that come from Anedi Akpan, the Executive Director, Drug Free Implemental Healthcare Organization, and Abba David, the Program Officer, leadership. Therefore, and also solidarity that comes from my team members. I decided to stop taking drugs so I could be a better to serve my community. I went through a cold and detox from heroin. I look forward to arrival of methadone in Nigeria, so as my peers have access to opioid agonist maintenance treatment to give people on opioid when they want to make positive change around their drug use. When I first started injecting, I was used oversized injecting equipment, which is green 1.5-inch needles with 5 ml barrels. This oversized equipment is all that was available as of that time, and it was painful to inject. And it left heavy scarring. The heavy scarring leaked unwanted police attention, exposing us to criminalization and corruption. This also leads to people injecting in the high-risk injecting site, like back of leg, inner arms, to reduce the risk of police detection. This shows how to promote on harm reduction can be harmed by heavy criminalization. I was very satisfied to be one of the peer worker consulting and trained in 2018 to support the introduction of needle and syringe program pilots in Nigeria. This includes a review of how much better quality injecting equipment, including the low Dead Space Syringe and needles, were able to meet with international consultants from coach and frontline aides, alongside with our federal we were able to consider a benefit of much finer and shorter low-dead space syringe. We understand that there is much less blood left in the syringe, and the fine needle also release much less blood from the injecting site into the space where drugs have been preferred and used. We could also see the value of some of our having access to syringe which separate the loaded space needle, and for people who have problem finding their veins. It is very nice to have this type of specialist equipment that reduce the harm associated with the injecting drug. We are also able to tell international community, lead technical advisor about our local patents in injecting pedins and ketamine in opioids in ampoules. This supported a discussion about the need for larger size syringe given to a larger volume of liquids in those ampoules. It is great to know that our feedback is now being taken on board by partners like Exchange Supply, and they design tailored the injecting equipment that meets the both needs of practical realities faced by people who inject drugs in low and middle income countries. It was a great to come out with a planning and implementation phase of Nigerian needle and syringe program piloted in 2018, which I clearly recommendation around 3 types of needle and syringe that should be provided through the NSP program. However, it is disappointingly that those recommendations were not followed through into the procurement process. Instead, but the wrong type and poor quality equipment was purchased. We were provided with a single-use vaccine syringe, which cannot be used by people who inject drugs, as insulin combination syringe, but with a short needle for injecting drug, undermine the skin, and a low-grade blue needles 3 ml syringe. Only that last option can be used by the people who inject drugs. However, the low quality of equipment have been resulted in people who inject drugs facing problem with needles detaching during the injection. In one case, surgical intervention was required to address a detached needle that was plugged into a vein of our community member. It is only because of DAFO has built strong relationship with the state hospital, that state specialist hospital, who have turned into develop expertise in working with the people who use drugs that decline could be pursued to stay and receive a surgical intervention. This story shows that we must educate procurement terms so they understand which type of equipment are suitable for the needle and syringe program and what is required quality standard. It was frustrated that DAFO community lead feedback of the needle and syringe was ignored until the advice was confirmed by the international community lead consultants. We hope this will be a point of learning for the partners known by buying harm reduction commodities. It is going to take a time to educate local peers about new range of low dead space syringe and needles. They are familiar with the oversized equipment, but they are also looking for a better quality and more appreciated equipment. In this UNITAID project, we will once again be able to consult people who inject drugs in Gombe State so we can tailor our state NSP stock release to meet their preferences. As access and trust status with the local drug using community. So those are the syringe available as of that time. 1 ml insulin, BD, 1 ml solo shot, 2 ml detach. So this me together with my peers at one of our hotspots in Gombe. Thank you very much.
Thank you so much, Abdullahi. We really appreciate that. And I think the emphasis on local knowledge and local expertise cannot be emphasized more because, you know, international consultants having to come in and then with only a global understanding of things is just not where we should be moving forward in terms of implementation and particularly design of programs. Thank you so much. Our next speaker is John Campbell, who'll be talking about the experience in Scotland. Scotland is actually one of the only countries in the world that actually implements low dead space syringes to scale in the whole of the country. John has almost 30 years work experience within the harm reduction field in the United Kingdom and Europe. In his current role, he manages the UK's largest program across 90 outlets. His particular area of interest surrounds all aspects of injecting drug use. He developed and implemented key harm reduction initiatives around the world, including one AccuVein Advanced Vein Finder, Glasgow's Image and Performance Enhancing Drugs Clinic, and more recently, the introduction of the city's first outdoor accessible sharps bin. John is a member of the Advisory Council on the Misuse of Drugs Technical Committee. Thank you so much, John.
Thanks for the kind introduction, Colleen, and also thank you for the opportunity to present to the delegates today. So I guess I'm going to take a look at the reasons we introduced our low dead space syringes with a degree of urgency. And as you can see from the title there, that was in response to an outbreak of HIV. Okay, and my slide's not moving. Oh, there we go. So we first identified an outbreak of HIV back in 2015. By the end of that year, that outbreak had reached 47, and it peaked around about 2019 at 190 cases. Now, I know for a lot of partners, you know, sitting around the table just now, that will not seem like huge numbers, but it was very significant numbers for us in Glasgow City. So we were able to very quickly identify where that outbreak had occurred. The outbreak had occurred, and in the early stages was certainly confined to Glasgow city centre. We were able to look then at in detail the equipment that clients were taking and using. And when we did that, we could see there was an abnormally large number of detachable equipment, so a large number of 2.5 milliliter barrels and detachable needles. And the reasons for that have already been covered. You know, we're providing equipment to long-term injectors, the majority of who were injecting into the femoral vein and needed long needles in order to reach that. And the risks associated with that barrel in particular, with the hollow chambering end, have been well covered up into this point. So we were aware that was really high risk. Now, what was also happening at this time was the development of low dead space needles. Low dead space needles designed to attach onto the end of that barrel and kill the majority of that dead space. However, they were still really being developed at that time, and it didn't have the full range of sizes that we would have needed. And I think if they had the full range of sizes at that particular time, we would probably have went with the low dead space needles. But they weren't, so we had to look for some solution. So we worked closely with our suppliers and the manufacturers to redesign the plunger part of the 2.5 milliliter barrel. And that was for the grommet, if you like, the pistol to get down and kill the majority of that dead space. But of course, in order for us to get our suppliers and manufacturers to commit, we had to give them some guarantee as well. If they produce this for us, then we'll, you know, certainly purchase them off them. And we made that commitment. The rest of Scotland were watching with interest in what was happening in Glasgow, not just, you know, the outbreak of HIV, but how we were responding to that as well. We've always had a very tight-knit network of health boards who often move as a unit. So, for example, we produced injecting equipment provision guidelines, and they clearly state the need for low dead space equipment, and they clearly state that anyone providing injector equipment should be providing the same range of equipment. Yeah, but we also consulted with our needle exchange workers forum, so frontline staff, and we consulted with people who were currently injecting drugs as well. And by the April 2016, it was only the new low dead space barrel that was available. Now, we had a real choice to make back then, because we had produced this new barrel that we hoped, you know, by reducing a lot of the dead space, would have stopped some of the transmission of HIV, but there was no certainty. And what we didn't want to promote to clients was, look, this is now equipment that will reduce the risk of transmission if you share it, because you've essentially just promoted something that will share. We also didn't want to say to clients, look, this is something that's going to get all the drugs out that syringe. when the reality is we know that the fixed needle and syringe, a more typical insulin type syringe, was always going to be lower dead space, so we didn't want to divert people away from that either. So we took the decision as the mechanics of that barrel were exactly the same, just to make that straight swap. We've now provided around 4 million of those low dead space barrels without any complaint whatsoever from our clients. And I guess to look at where we are now in Scotland, there's been recent further developments. You can see there just the different types of needles and syringes, and relative to their dead space highlighted there, obviously with the blood in red. So you can see that if you the second, if you like, from the left that I have circled, that's a low dead space barrel. Yep, it's gone down, it's taken away almost all of that dead space, and there's now a new low dead space needle that for the first time is designed to be attached onto a low dead space barrel. And I believe that takes the volume of dead space very, very close to what we'd expect to see in a more typical fixed needle and syringe, a more typical insulin type syringe. So the reality is, for all the equipment that we now give out in Scotland, regardless of barrel, regardless of needle, it could be classified as low dead space equipment. And of course, I use the term low dead space equipment and understanding that, you know, that there is no set measurement for what, you know, quantifies as low dead space or as ultra low dead space, yeah, across the board. Okay. Thank you. And if anybody's looking for further reading, you'll be able to see one of the responses that was made in relation to that, and it's very easy to find online. Thank you.
Thank you so much, John. And it's really interesting, and maybe people have questions. We can talk about it later about the low dead space needle as well. Next is our speaker is Annie Madden, who is the project lead and principal investigator for the CUTS Hep C project at the International Network of People Who Use Drugs, INPUD. Annie has a PhD from the University of New South Wales in Sydney, Australia, and a background in qualitative social sciences research and community-led methodologies. She has been involved in drug user-led organizations in both Australia and globally for almost 3 decades. Thank you so much, Annie. And please do put your questions into the Q&A. We'll come back to you in after the speakers.
Okay, thanks, Colleen. It's great to be here, everyone. I'm going to jump straight into it, so don't have a great deal of time. But I've been asked to speak briefly to take you through the community-led values and preferences research that underpins the low dead space syringes and needles study that's being undertaken by all 3 consortium that are part of the UNITAID HCV portfolio projects. But just before I get into the methodology for the low dead space values and preferences research, I just want to stop for a minute and focus here on the actual overall study goal for the low dead space syringes and needles study, because as you can see there, our overall goal is to generate evidence on sort of the feasibility, the acceptability, sorry, my slides just went backwards, feasibility, acceptability, and impact of implementing programs for the distribution of low dead space syringes and needles to people who inject drugs, with other goal of informing global guidance and recommendations on low dead space syringes. Now, as you can imagine, achieving that broad goal is not going to be done by community-led values and preferences research alone, and there's lots of other research that is part of this broader study. But I would say that the values and preferences research, the community-led values and preferences research, is in fact the most important research that we'll be doing, and I'd like to just sort of focus on why I think that's the case. So as you can see here, this is just a diagram of the overall study design. And you can see there's lots of research that will be going on. That big blue bar through the center is the community-led values and preferences research. And as you can see, it goes right across the research for all years of the research. And to me, you know, that sort of says right off, looking at that this is the kind of backbone of the research that we're doing. It is the foundation, you know, and I think there are a number of reasons why it is so important that this research is the backbone of what we're doing. So since I've been working on this study, I have heard more than one person say, you know, why are we doing all this values and preferences research? Because, you know, we already know what people who inject drugs think about low dead space syringes and needles from other research, mostly research in high income countries, as we've heard. But I guess what I would say to that, and what I think is important to remember, is that every context is really different. And even some of the seemingly small differences can be really, really important, particularly when it comes to harm reduction and injecting practices. And we've heard some of those issues described already in this webinar. It's often things that can go unrecognised, unacknowledged, not noticed at all. So I think it's really important. You know, we've already heard tonight that, you know, low dead space needles and syringes have been around for some time. Indeed, we've had a recommendation from WHO since 2012 that they should be used in harm reduction settings. But as we've also heard, they're still not well used outside of high income settings. And we think that's because of a lack of proper consultation with the community. And even where consultation does occur, often the community is not listened to, particularly in low and middle income settings, as we've heard already this evening from our community speaker. So this often, what happens in these situations is even if community is consulted, or if they're not consulted or not consulted properly, we end up with equipment being distributed that is not fit for purpose for people, and certainly not fit for the specific context that people are in, such as giving people 1 ml syringes when what they mostly want to use is 3 ml syringes, for example. And unsurprisingly, the community then don't want to use that equipment or end up having to modify equipment to make it fit for purpose in some way. And then we end up hearing that people don't want to use low dead space syringes and needles. So this is where values and preferences research really comes in, to my mind. Like other research, it can help us to understand issues and people and context better. But unlike most research, it's also fundamentally about community empowerment.
Oh, sorry, Annie, we seem to have one of the interpreters coming through. Pauline, if you could please fix that, that'd be great. Go ahead, Annie.
Okay. So as I was saying, unlike most other research that happens, values and preferences research that is community-led is also fundamentally about community empowerment. It's about building consensus, and it's about galvanizing community ownership. The community truly being heard, being able to speak their truth, and perhaps for the first time, really being able to be heard by those who make decisions. It's about community leading on the questions that are asked, how those questions are asked, and on the potential solutions. Sorry, backwards. My slides are very sensitive tonight. It's also about community being involved in every single stage of the research. So from the concept right through to the dissemination and every stage in between, which is what we're doing here. To my mind, when we're talking about community-led values and preferences research, I think it's about, you know, stopping to think about people who inject drugs merely as beneficiaries of services or programs, and rather seeing us as experts in our own lives. And like experts, we want to lead in the knowledge generation on the issues that affect our lives deeply. And this is one of those issues. So with that said about values and preferences and community-led values and preferences research in particular, I just want to finish with a couple of slides that are going to take you through the methodology itself of what we're going to be doing. So as I showed you on the overview slide of our study, there's the research is over 3 phases and 3 different lots of focus groups. The first phase is a pre-implementation phase. The primary objective of that is to evaluate community values and preferences in relation to low dead space syringes and needles in the context of other harm reduction supplies that are available to people in the 10 low and middle income countries involved in the study. The first focus group will involve about 25 participants per site, and many countries have multiple sites. We'll have small focus groups, 5 to 10 people, so we can really encourage rich and a lot of discussion in each of those. And importantly, they'll be facilitated by a trained and supported community researcher and note taker. And Input is at the moment developing research that will be used to train the community researchers and note takers. The participants will be people who inject drugs. They'll be identified and recruited through word of mouth and community networks and peer educators and harm reduction people on the ground. In that first focus group consultation, we'll be showing multiple brands and samples of low dead space syringes and needles of different sizes, gauges, volumes, types, along with the equipment that's currently available, as well as high dead space products will be shown, and then they'll be demonstrated, and then we'll discuss those products and assess initial values and preferences. The focus group will also focus on which products will be piloted, if any, and the preferred model or approach for piloting those brands, like how they might be made available or packaged or whatever. And there'll also be some discussion around knowledge mobilization activities around IEC materials that will be used in the pilots phase as well. And participants from the first focus group will be invited to participate in the second phase pilot. So the phase 2 pilot, its primary objective is to gather community preferences regarding the proposed low dead space syringes and needles, and to confirm which products will go through to the phase 3 wider distribution. The participants from phase 1 focus groups who do elect to participate in the pilot will be able to access selected low dead space syringes and needles via their usual NSP program, however that operates, for a period of around about 6 weeks. Toward the end of that, pilot participants will be invited back for a second focus group, which will operate on a similar basis to the first focus group in terms of size and scope, and again by trained community researchers and note takers. And during that second focus group, participants will be asked more about their experience of using the piloted low dead space syringe and needle products, report their overall impressions from using those products, and if they would use them in preference to other injecting equipment or not. And they'll also be asked about the value of the IEC materials and whether other materials might be needed for the third phase. And then finally, we have the third phase, which is the implementation phase. That runs for a much longer period of around 18 months. The primary objective here is to assess the acceptability to community of the low dead space syringes and needle products that are distributed in this final phase. The products that are selected will be made available to all beneficiaries. So that's not just the people who've participated in the one or two focus groups prior, via their usual NSP or harm reduction program for the implementation period. Towards the end of that period, again, we will run a focus group that's facilitated by a trained community researcher note taker around the same size and scope. And during that third focus group, participants will be asked about their experiences of using low dead space syringes and needle products over that longer period of time, report their overall impressions from using the products, if they use them all the time, only some of the time, whether they would continue using them, whether they would use them in preference to other equipment if they were made available ongoing, etc. And participants, again, will also be asked about the value of the IEC materials, knowledge mobilization activities, and whether further materials and activities might be needed for the ongoing availability should that occur. That's it. That's the methodology. Hopefully I've touched on why it's important as well. I just wanted to finish here by saying I'm presenting on behalf of Input. I'm involved in the Medicines du Monde led consortium, but there are 3 consortiums in this work, piles of organizations involved. There's all their logos. Thank you.
Thank you so much, Annie, for that. Let's move on to our last speaker. Kanishk Gupta has been working toward introducing innovative and underutilized products in low and middle income countries for over 13 years. His work experience spans across pharmaceuticals, medical devices, and diagnostics for both private as well as the public sector. Kanishk is working as a market shaping officer with PATH under the UNITAID hepatitis portfolio towards end-to-end market-shaping initiatives for improving equitable access to both low dead space syringes and needles and long-acting depot buprenorphine. Thank you so much, Kanishk.
Thank you, Colleen, and everyone listening here. A very good morning, good afternoon, and good evening to all, depending on your location. In the next 5 minutes, I will briefly talk about PATH's work in the syringes space, provide a snapshot of how the global low dead space syringes and needles or LDSS commodities market looks like, what are the access barriers, and how we can work together to overcome those. PATH has been a leader in the syringes space since 1980s, working across different phases, right from product development to technology evaluation, commercialization, enabling local manufacturing and market dynamics. One such example is when PATH worked in Vietnam with the community and a local manufacturer to iteratively design and develop a prototype for low dead space syringe product preferred by people who inject drugs, testing it in our lab in Seattle and enabling local manufacturing. Moving on to the global market landscape. So the syringes and needles market for low dead space in 2022 looks slightly skewed because of the impact of COVID-19 vaccinations, and harm reduction is estimated to be around 15% of the entire overall global market for low dead space syringes in 2022. However, the detachable needle design still dominates at 64% as compared to the fixed needle design, which is 36%. In terms of the syringe barrel sizes, 1 ml has the highest share, about 43%, followed by 3 ml barrel size at 36%, and distantly followed by the 5 ml barrel size at about 9%. The government and NGOs basically lead the market, contributing to 70% as compared to just 30% in the private sector. In terms of income level, high income countries, as we are quite aware, so they dominate the market at around 88% of market share as compared to only 12% for the low and middle income countries. Towards the right side of the slide, you may see a list of global suppliers. Now, this is just a few suppliers that we've put here for indicative purposes, which we have found relevant till now. And this is not exhaustive as of now, and we are further working on it to develop them further, and we'll share them subsequently. Now, moving on to the LMIC market, or low and middle income markets. There are many market shortcomings in these LMIC market, and when we talk about LDSS product categories, which is low coverage of needles and syringe programs, limited awareness of benefits of LDSS products among people who inject drugs, lack of information on LDSS products for planners and implementers, a lack of clarity on PVIT preferences or people who inject drugs and their preferences, high cost of in-country costs of these LDS products, and will further all these shortcomings translate into systemic access barriers, which include first a limited availability of preferred products of LDSS, which are preferred by people who inject drugs in LMICs. Secondly, high in-country costs for LDSS products in those countries. Third very important factor or barrier is lack of awareness and demand, limited evidence available on acceptability, communities' values and preferences, which we've spoken at length in this webinar till now, feasibility and cost effectiveness, lack of clarity on the market size of the target population for LDSS products. And last but not the least, unsuitable models of care and service delivery for people who inject drugs, supply-related challenges for the products in the hepatitis C virus prevention products space. For the way forward for improving equitable access to low dead space syringes and needles for harm reduction in low and middle income countries, here is what you can do about it. First, consider included LDSS as part of the overall needles and syringe procurement in your programs. engage with the communities and incorporate their values and preferences into planning procurement for needles and syringes in low dead space and include low dead space syringe and needle products. Follow us for more resources and guides in this space, especially on the suppliers and products. Reach out to us for further information and shared learnings. And then what we are planning to do in this space is ourselves conduct with partners values and preferences study to understand the preferences of people who inject drugs. And then based on these learnings, we will finalize a comprehensive market shaping strategy for LDSS products in low and middle income countries. With partners, we are developing a short list of LDSS products, which we are calling as a LDSS starter pack, to be utilized in the UNITAID studies. And we will subsequently use the different focus group discussions to select a few products out of this longish list to further implement and do wider distribution. Then very interesting part is in partnership with Input, which is International Network for People Who Use Drugs, and MDM, that is Medicine du Monde. We are developing a guide for good practices and principles for needles and syringes product selection. Next, we will be developing an LDSS supplier landscape, as I've mentioned earlier. And towards the end of our grant period or end of the project period, we will synthesize all the learnings and analysis to come out with a comprehensive market report. Very important at this point is to make aware that we are also working very closely with the Global Fund, which is like the single largest procurer for international funder for syringes and harm reduction products, is to work with them to include LDSS products within their pool procurement mechanism, that is the WAMBO platform, to encourage and guide grantees and principal recipients to procure the preferred LDSS products for through this platform. Lastly, we are also further exploring opportunities for encouraging local manufacturing of preferred LDSS products. I will end here by just stating that a coordinated effort amongst all of us will significantly help in overcoming the barriers for adoption and advancing the markets for LDSS in low and middle income countries. Thank you all. Over to you, Colleen.
Thank you so much, Kanishk, and thank you all for amazing presentations, and particularly Abdullahi for your presentation, which really gave us the founding, the foundation for how we should approach these implementation and design of programs as we move forward. So there are quite a few questions. I've just brought Jack Stone from University of Bristol to answer some of the questions that I saw around the modeling, because then, Jack, we can also have them interpreted. So Jack, if you wouldn't mind, we'll come to Isatu's question, which I am trying to find. I saw that. Your question, what impact could using LDSS have on an HIV epidemic where high dead space syringes are currently used? So I saw that Ernst, you responded a little, as did Jack. But Jack, if we could come to you first, and then Ernst, maybe you after. Thanks, Jack.
Thanks, Colleen. Can you hear me?
Yes, we can hear you. See you clear.
So thank you for the question. So in our modeling, we found that the impact for both HIV and hepatitis C varied substantially between countries. And this was dependent on the existing coverage of needle and syringe programs in the countries, the level of existing high dead space syringe provision within NSPs, and also the prevalence of HIV and hepatitis C. So we did model 16 countries, and we used an existing model that has been developed in collaboration between Bristol, University of California, San Diego, and University of New South Wales. So at the moment, we've got results for 16 countries, but we're hoping to expand it, and so hopefully make some of these projections more generalizable. But at the moment, what we can say is that in the countries with very high or with high NSP coverage, so above 40%, about 8% of new HIV infections could be averted between now and 2030 if NSP switched to using low dead space syringes. In countries where the needle and syringe program coverage is lower, so below 40%, and HIV prevalence is below 30%, then 8% of HIV infections could be averted. And then in countries which have very low NSP coverage, which also other countries with very high HIV prevalences, then only around 1% of new HIV infections could be averted. But there's a lot of uncertainty in that, and this is across countries, and even within these different groupings, there's a large heterogeneity in what the model is projecting. So the impact is very context specific.
Thanks so much, Jack. Ernst, did you want to come in on this question as well?
I was basically looking in the list if I could spot Jack or Peter to reply to this. So in the absence, I just said I didn't know. But thanks, Jack. Sorry, I didn't see you in the list. Great. No, but I think just this is a fundamental question when it comes to low dead space syringes. We approached what we do at the moment based on two hypotheses. One is that we need to make sure that whatever we're offering is adapted to the needs of the clients. That might be one of the reasons why there's not enough of them. And the other is because there's not enough data right now to build your case, right? Why would you potentially pay a little extra, and what is the benefits of it? So it's the work Jack is doing is fundamental to push this this subject on the global agenda, and I think that 8%, maybe just as pick a number, doesn't immediately maybe strike people as look a really high number, but it is massive. If you look into all the effort we're putting into as an implementer, just trying to get the syringes in the field, all your teams, your context, the conflict areas, everything, all of that, just to get syringes in the field. If you can maximize whatever you're doing right now by simply changing the syringe and you win 8%, my God, I'm taking it. It's huge. So, and this is on a global level, and the only thing you would need to do is change the syringe for another one. It just happens, clicking on ordering this syringe or that syringe, and you win this amount. It's enormous. So yeah, I'm very excited about the potential of this.
Thanks so much, Ernst. We have a question from Joaquin Levi. Some users complain that the plunger offers greater resistance during injection and prefer the usual syringes. How would you be able to respond to that? Annie, can I ask you to take this one? Or John?
Yeah, I'm certainly happy, Annie, if you want me to take that. Yeah, I think before you start to procure in large numbers, we have a responsibility to actually try the equipment out ourselves. I certainly know as part of our national procurement process, round the table, we have individuals that are currently injecting street drugs, and they're able to try that equipment out too. But I do have to say as well that, people don't like change. And sometimes that's well evidenced. Sometimes there's no real rationale behind that at all. And I'll give you an example that's not so much to do with needles or syringes, but we introduced foil. Then after we had introduced the foil, we asked people, their opinion on it. Some people felt it was too short. Some people felt it was too long. Some people felt it was too thick, and some people felt it was too thin. So I don't think you're going to please every person. But what you're purchasing is a medical device, and if that medical device is sticky or it's not working properly, then of course you have issues. But we also have to put a lot of faith in the suppliers and manufacturers to get that right as well. Okay.
John, also, could you tell us a bit more about how you practically went about informing clients about the potential benefits of low dead space syringes? Yeah, while, because you touched a bit on this about not making sure that people got the right message around the switch.
Yeah, but we didn't inform them. We sent out no message whatsoever because the mechanics of the equipment hadn't changed. there was no choice for people. They didn't have a choice of, you know, low dead space and high dead space. We took the decision to make sure all the equipment was going out. What we did promote and what we continue to promote is a step before this, of course, which is the promotion of single use of injecting equipment. You know, and we go to great lengths to promote that. I know most people here will be focused on a reduction in blood-borne viruses, but the reuse of injecting equipment and associated paraphernalia is a massive risk for vein damage, for skin and soft tissue infection, and a whole range of other complications as well. So yeah, even low dead space syringes may drive down the prevalence of blood-borne viruses, but needle reuse is still likely to cause significant issues as well.
Thanks so much. There's a question from Matt Jones. How much blood is required to transmit BBVs like, bloodborne viruses like hepatitis C when sharing a low dead space needle? Is the low space of blood remaining still more than enough blood to pass on the transmission via what's left in the low dead space? Who would like to take that one?
I'm happy to start talking to say that I think we don't really have a very precise answer to this unless Jack has a more specific answer. But I mean, what we know is that the virus is obviously smaller than the blood platelets. So if there's blood, then, you know, there will be virus in it. The least blood you have, the least virus you will have. I don't think we have a global, unless anybody in the audience or panelists has a more specific answer, but I think that where we stand is less blood equals less virus, and I don't think there's a cutoff point where we can say, okay, if there's less than this amount of blood, then the risk of transmission is almost annihilated. I don't think that exists.
John, you're nodding. Anybody else? Robert? Nope. Okay. Last question here I've got from Issa Tussar. Since low dead space syringes are more cost effective, especially in reducing medication waste, is it always readily available? Kanishk, can we come to you?
Sure. So a very short answer to this is no, they're not readily available. And wherever they're available, they may not be the most preferred or the most appropriate. I think that's the entire premise of all the discussion today, is that first, enough equipment is not available. Second, the most preferred or most appropriate equipment is not available because nobody or very few people have the understanding to this. And that's exactly what we are trying to study and then advocate for scale up.
Thank you, Kanishk. There was also a question in the chat. It wasn't in the Q&A box, but I don't know who actually said it, but they asked, what do you see are the benefits of LDSS outside of harm reduction for people who inject drugs in terms of the market? I'm not sure.
Well, there are different applications of low dead space products. So I think on one of my slides, we saw that vaccinations is a big market. Harm reduction is another one. COVID vaccination has kind of taken over the entire market in the last 2-3 years. It did not exist in 2018, but it is the dominant application, so to say, for now. So in harm reduction outside of reducing infections, I think that's a tricky one, but I think the best alternative is to that says that because it has very low dead space, it optimizes the amount, the substance present, and you don't lose the substance that the people are injecting. So I mean, it will optimize, it will save you cost on that as well. So that's probably the other reason that I could think of.
I did see questions in the chat, but they're from a Russian participant. Is it possible for one of our interpreters to please let us know what those questions are, so we can try and answer them? If you could put it into the Q&A box, that would be fantastic. Thank you so much.
Can I, in the meantime, perhaps when that happens, Colleen, just bring back up the discussion around how do you communicate on low dead space syringes? Because I also see Jamie popping in after John mentioned how do you promote low dead space syringes without providing this, well, without suggesting to people that the risk of transmission, I mean, there's less risk of sharing. And I suppose I'm struggling a little bit with myself, because you want people to get all the information. That's and the reason we are doing it is not because people will have, you know, like the total dose concept, like, okay, you won't lose any drugs, because reality is people flush, and that concept doesn't really apply. So it's, how do you communicate this on an honest way to people without increasing risk? I'm a little torn, I think, I suppose, on this. The WHO recommendation says that low dead space syringes should be provided with the information of the potential benefits. I can see how in certain contexts we might be careful around this. But I'm really hoping that we will learn a little bit more about this to, you know, Annie, maybe throughout the implementation. How does that work? Because low middle income country settings will unlikely be like high income, where people might have 15 different options available and they go about whatever they prefer. And I find that scenario very unlikely. Mostly in low middle income, hopefully people will have more than one choice, but when it comes down to reality, people will have only one option in the end. So yeah, I think there's still a lot that we need to find out around this. But it does, what I'm hearing now, it questions perhaps a little bit how the WHO has formulated their recommendation.
I agree though, Ernst. I think it is, you do have to provide people with the information. And we have been talking about this very issue in the development of the IC materials that will be distributed during the values and preferences work. And it is, though, about sort of being really honest about the environments. I think this is the value of having community-led research, because it provides opportunities for really in-depth discussions among peers in a safe environment where we can dispel myths and misconceptions, but we can also talk frankly and honestly about things that often can't be discussed out in the broader community, or there isn't time, or it's risky, or everything's so rushed because people are worried about coming to police attention, that those moments for that sort of peer-to-peer education, intervention, and talk about strategies and options are not always there. So these processes are really important, I think. You know, this is why it's not just a quick one-off consultation. This is a long process, and not just about the equipment. You know, this is about the opportunities for education, for empowerment. There'll be advocacy work that is also part of this process. You know, we're doing community-led monitoring, capacity building and work as well, that will also be about, you know, a process of how we improve the environment more broadly in low and middle income settings around harm reduction supplies and, you know, coverage, and not, so it's not just this really singular focus on sort of low dead space, you know, syringes and needles, which has been said a few times. It's a tool, it's not the be all and end all, but, you know, this is why it has to be part of a suite of work and a comprehensive approach, I think, which is, and very community led from start to finish.
Absolutely.
Yeah, I think, Annie, also coming back to John, because John, I think the way you went about it is making sure that people who use drugs didn't really have to adapt to anything, because it was the producer that came up with something that was exactly the same. So for the user, there's no adaptation required. I think that is maybe something that we really need to have as the aim ultimately, that if we provide an equivalent, then for people it should make a difference to use a high or low dead space syringe. Therefore, you know, why not provide the one that has the best protective measures?
I think, though, that we still need to be very guided by community, even in those sort of settings, though, because, you know, I know that people can be very sensitive even to the changing in packaging, for example, even if the equipment is exactly the same. So it is really about informed decision making, I think, that's community led.
Yeah.
Absolutely. We only have a few minutes left, so let me attempt to wrap up this incredibly rich discussion. Though, you know, we shouldn't say rich discussions anymore. My goodness, I feel like I should be fined for using that word. But for the amazing expertise that was shared today. And I think some of the key messages that we can take from this webinar are that WHO has made this recommendation, and so it can be adapted at a country level anywhere. It's that a diverse set of tools should be made available to people who use drugs based on their values and preferences. I think the key message here is that if we actually want to have good implementation, we must have people who use drugs included in the concept, design, implementation, and monitoring of any program. I think Abdullahi's perfect example of what went wrong, even, because that local expertise and that local knowledge was not taken seriously. And with the current crisis in harm reduction funding, we cannot afford to waste resources by not actually having people who use drugs involved in every step of the program development and implementation. We heard that procurement policies need to be adapted along with the changing technologies. In the report, Robert highlighted quite a few areas where we saw that it was taken into consideration during the program, but then the procurement didn't change, so people didn't have those options available. And so that needs to be part of a redesign process as well. We are all looking forward to Pat and others who are developing comprehensive market shaping strategies for how we can actually get more of these products out. And, at HRI and together with our partners, when we do hear about new developments in technologies like the low dead space needle, we will share that when we have more. I think it's really important to also note that, the modeling that Jack and Peter are doing actually showed that if we do switch from low dead space syringes and a needle and syringe program coverage remains the same, then we could actually avert 14% of HIV infections between 2024 and 2030. And when we have so many targets to achieve by 2030, why wouldn't we utilize every possible tool available so that we can actually offer people a change in their lives? On that note, I want to say thank you all so very much to our amazing speakers. Thank you to everybody who joined us online. We really do appreciate you spending your time with us. And we will be making the recording and presentations available on the HRI website. And we hope that if you have any questions, just reach out to us. We will do our best to answer those questions or get it to the right person. So thank you all very, very much. Have a wonderful rest of your morning, afternoon, evening, and we'll see you soon. Thank you all. Bye.
Bye.
Thank you so much, Abdullahi. That was amazing. Your presentation was fantastic. Much appreciated.
Thank you, Annie. I really appreciate it. Thank you, Collins.
Okay, bye. Thanks,
Yeah.
Ernst. Thanks, everybody. Thank you to the interpreters.